It's day 2 of NEI Synapse, and we are here with Dr. McIntyre for an extended Q&A session. Let's listen in as he addresses your unanswered questions from today's presentation.
In today's session, we covered the topic of depression, dementia, the dynamic duo, particularly focusing on aspects of cognition, taking a more transdiagnostic perspective on this common phenotype, that being cognition, wherein throughout the presentation I covered not only the types of cognitive dysfunctions patients in psychiatry often experience, but what this means for us from the point of view of conceptualizing the underlying causes, that is the pathogenesis, as well as what this means from the point of view of how we can help patients who are experiencing cognitive difficulties. One of the questions that's come in from our audience is, are the brain changes in obese patients possibly connected to diabetes and insulin secretion? This is an excellent question, and it's part of a larger neuroscientific inquiry regarding the interface of obesity with the central nervous system. And what we've now learned is that individuals who are affected by obesity, notably abdominal obesity, are more likely to exhibit changes in the structure, in the function, and the connectivity of their brain. In other words, what we notice is at the central nervous system level, the sort of gross level, is that there are losses of brain tissue in certain parts of the brain, and these losses of brain tissue have in fact been highly replicated. When we actually cascade down and look at the cellular level, in other words, we start to zoom in and try to better understand what's accounting for this volumetric loss, what's discovered is something very interesting. What we discover is, yes, there are in some cases loss of neurons, that is the gray matter, but what's really noticed is in fact the loss of white matter. And the loss of white matter is not just of academic interest. We used to think for a long time that white matter was simply the scaffolding, the glue of the brain. And in fact, this derives from its name, glia, meaning glue, named by Virchow. What we've learned in the last decade to 2 decades is that along with offering scaffolding or structural support, the glia are relevant to the neurochemistry of the brain, involved in GABA glutamate signaling, but also involved in the inflammatory milieu of the brain. Taken together, what we know is that obesity affects the structure and function of the brain, notably the circuit interconnectivity, and it does it through a variety of effector systems. I often say that obesity metastasizes to the brain as a metaphor for the effectors. And what I mean by effectors are insulin dysregulation and inflammation. For example, the question pertains around insulin, and is that the critical mediator of changes in brain function and structure in people obese? And yes, that is one of the key effectors. For example, we know that insulin, which is well established as playing a key role in peripheral glucose homeostasis, is in the brain as a neuropeptide. In other words, it's there to facilitate neurodifferentiation, it's there for neuroplasticity, and also to protect the brain against insults like inflammation. And when there's a disturbance in insulin signaling or insulin availability, what we observe is progressive changes not only at the cellular level, but the circuit level in the brain. And this has been shown in animal models, also shown in humans who have prediabetes or just frank diabetes. So we in fact believe this is one key mechanism or effector that's linking obesity to the brain, and this alongside with inflammation likely accounts for the brain volumetric and structural changes that we see. One of the additional questions we have is, what do you think about the construct that depression can be an early presenting symptom of dementia? I think this is a really intriguing area. I would encourage people to think about depression in 3 ways in the context of dementia. First, that depression is an antecedent. In other words, it is almost a prodrome or a predecessor of sorts to dementia. Secondly, depression often complicates dementia. That is, a person who has, for example, Alzheimer's disease. 20 to 40% of these patients have depression at any given point in time. And then third, and not mutually exclusive, depression could follow the onset of dementia. What does this actually mean? Well, we know that depression is a serious syndrome. It complicates dementia, and outcomes in people with dementia are only worsened and accelerated when people who have dementia in the absence of depression. Academically and from the research perspective, there's a variety of interesting questions that immediately arise from this observation. Is it the case that depression is causing dementia? Is it the case that depression is an early manifestation of a dementia propensity, just manifesting as depression early on? These again are not mutually exclusive possibilities. The other part is, what's the neurobiology? Why would it be that depression, particularly multi-episode depression, increases the risk that a person would have dementia? Well, many theories are out there. One really intriguing possibility is that some of the changes in the stress hormones, the HPA axis, some of the changes in the regulatory system, you're thinking about insulin and glucose, maybe alterations in inflammation or the inflammatory tone or what we call meta-inflammation. Maybe it's through some type of oxidative stress effect, which we know is a replicated biological change in depression. Any one or more of these effectors or mechanisms can really, in fact, be a combustible or form a combustible mix on the brain, resulting in a dementia phenotype. So certainly this is something that's possible. From the treatment perspective, there are opportunities. If depression is a predecessor and possibly causing dementia, then treatment of depression, does that actually reduce or have some moderation effect on dementia risk? We've got some reasons to believe this is the case, particularly with lithium, wherein lithium's now been shown to not only reduce episode severity, duration, and frequency in mood disorders, but it may also mitigate the risk for dementia. That is, anti-dementia properties are suggested by lithium. And this may be because of the effects on depression, effects on insulin signaling, or maybe lithium's effects on amyloid production. So all very interesting indeed. This segues perfectly to one of our next questions from our audience. Would I proactively give lithium to a 79-year-old female with mild cognitive impairment, MCI, type 2 diabetes, and a history of depression currently taking escitalopram? If so, what would be the titration target level? Well, certainly in theory, I might consider that, but in practice, I may not. I don't want to give the impression that lithium is, first of all, FDA indicated or unequivocally been shown to be able to prevent deterioration into dementia in older patients. Moreover, lithium has not been sufficiently studied in someone who has MCI. We should highlight that lithium's anti-dementia properties have largely been looked at from the point of view, what's lithium's effect on mood, and to what extent can that mitigate the dementia risk? And we see something very positive. But with respect to a patient with MCI, we don't have evidence on lithium forestalling or reducing the declaration of Alzheimer's disease later. But I would like to emphasize that tight control of diabetes and certainly attenuating the depressive symptoms with adequate pharmacotherapy and, where applicable, psychotherapy seems to be important moderational strategies, given the fact that we know that up to 20% of Alzheimer's is caused directly by obesity, hypertension, metabolic aspects. One of the questions come up regarding comments on caffeine and cognition. Certainly caffeine does have pro-cognitive effects, and so does nicotine, which often is accompanying caffeine. But in the long term, we don't have long-term studies regarding caffeine. And I think we are clearly going to need those with respect to cognition. There was some interesting literature that came out that perhaps caffeine ingestion could reduce the risk of some cognitive problems or even type 2 diabetes. But I think that we're going to need more science before any strong assertions or statements can be made. Certainly in the case of nicotine, we were made aware of the fact that in the short term, nicotine is pro-cognitive. It can improve your cognitive abilities if you, for example, smoke a cigarette or have nicotine delivered into your blood, say, through a patch. But over the long term, nicotine appears to be anti-cognitive, and that's certainly a reason why we need to be very cautious in extrapolating short-term to long-term results. Next question is, what about venlafaxine for depression and Alzheimer's? Is it preferred than an SSRI? Or vortioxetine? I would say at this point in time, we do not have any gold standard antidepressant to manage depression in an adult with Alzheimer's and depression. Secondly, the evidence base, which has been subjected to meta-analysis, provides a somewhat humbling report card, frankly, regarding the efficacy of antidepressants in depression and Alzheimer's, with most studies, in fact, being negative or failed studies, with very little lines of evidence that compellingly demonstrate that antidepressants are robustly effective. We have some leads, but it's an area that has had more negative and failed studies than positive studies. That being said, I would treat, and I have treated depression in persons with declared Alzheimer's disease with antidepressants. My preferred strategy is vortioxetine because it does have pro-cognitive abilities, and I cross my fingers and hope that may translate into an advantage for my patient. Secondly, I would consider an SNRI like venlafaxine or duloxetine because they do have some benefits on some domains of cognition, notably attention. That being said, the decision to use any antidepressant is going to be guided by other factors like other drugs that are concomitantly administered, that is, drug-drug interaction concerns, and also other aspects of the patient's presentation and their history. What I would emphasize, though, is SSRIs are not a popular treatment for me in treating depression in demented elderly because SSRIs dampen reward, cause emotional blunting, and a fogginess which clearly does not assist patients with dementia. One of the next questions is Victoza. Can that in fact help cognition? And the answer is preliminary results suggest so. We have animal work that suggests that liraglutide, which is Victoza, it's an incretin, a glucagon-like peptide 1 agonist, is capable of improving cognition in animals, and this has been translated into some results from my lab showing that liraglutide can in fact improve cognitive abilities in adults who do suffer from memory problems. Again, this is off-label. These are research-based questions that we have addressed in my lab, but we also in my clinic will give patients suffering from cognitive interference, we will give them Victoza or liraglutide off-label in order to help them. Our next question is lithium, can it be neuroprotective? If it's neuroprotective, why does it cause memory loss? This is a great question. So lithium clearly is neuroprotective and also facilitates neurogenesis, which has been important for neuroplasticity enhancement. So if that's the case, that is, it's neuroplasticity enhancement, it's neuroprotective, and it protects against Alzheimer's disease, why does it cause memory loss? Well, it reminds us of the pleiotropic or the very complex pharmacology of lithium. Lithium affects many different systems. And the short answer is lithium is affecting targets that we want, but it's also affecting targets we don't want, so-called off-target activity. For example, we know that lithium can interfere with anti-diuretic hormone. This is why patients often complain of increased urination when taking lithium. Keep in mind that anti-diuretic hormone is a pro-cognition peptide in the brain. And it's possible that lithium is interfering with memory in patients in part by blocking anti-diuretic hormone in the brain. That's a hypothesis. So the reason why we get these seemingly contradictory findings of lithium being neuroprotective and anti-dementia, but yet interfering with memory, speaks to the on-target and the off-target actions. The next question is, what anti-inflammatory agents are available as supplementation? There's been a huge interest in the last, I would say 10 to 20 years, particularly in the potential role of anti-inflammatory agents suppressing mania, improving depression, targeting negative symptoms, attenuating cognitive deficits, and so on. And this is built on a larger scientific framework where we believe that pro-inflammation is causing many aspects of psychopathology commonly encountered in clinical practice. For now, there really is no anti-inflammatory agent that we would describe as an agent that's ready for prime time, that's robust and reliable. We are getting some interesting results with agents like low-dose aspirin. People have been looking at other treatments like minocycline. There's been some efforts to look at the role of biologics like anti-TNF agents. And taken together, we are seeing some leads. In other words, we're seeing some hints of efficacy. But for now, there cannot be any strong statements made about any one of these particular agents. What I would say is that L-methylfolate, 15 milligrams per day in depression, is showing some very nice efficacy. And we include this in some of our guidelines, like the Florida Medicaid guidelines for depression, as an augmentation approach. And it's not without our interest that L-methylfolate is, in fact, anti-inflammatory. Next question is, does getting the patient to an ideal weight reverse the inflammation of aging? Does that include the use of bariatric surgery? And the answer is we think so. This is really, really interesting. Bariatric surgery, which is the most robust intervention for morbid obesity, has in fact been demonstrated unequivocally to be anti-inflammatory as well as insulin sensitizing. In other words, it normalizes the inflammatory milieu and it also has a positive influence on metabolic parameters. Moreover, what we know is that people who have bariatric surgery begin to exhibit improvements in cognitive functions. So that sounds something we would like, and obviously we do. Does it actually slow down the aging process? We don't know for sure yet whether bariatric surgery slows down the aging process, but something related to bariatric surgery absolutely does, and it's called calorie restriction. In fact, calorie restriction in animals is the most robust anti-aging strategy. And we have some data from our group, which we just recently published, showing that when human beings reduce their calorie intake, it actually preserves their cognitive function. So we have some suggestions that calorie restriction may slow down the aging process. Next question is, where would I find information on marijuana, medical and recreational? what I would suggest is go to the biomedical literature, that is PubMed, and look at some of the systematic reviews recently conducted, as well as some of the meta-analyses that have sought to determine what's the effect of recreational and other forms of cannabis on domains of psychopathology like anhedonia, like cognition. And what you will find is a consistent story that recreational marijuana is associated with psychosis in young people at risk, worsens measures of motivation as well as cognition. In some cases, these deficits in motivation and cognition are recoverable, but in other cases they're not. So check out some of the meta-analysis in this area. This question comes from a colleague. What questions do you ask to differentiate between fatigue and lack of motivation? I bring the point forward that motivation is often the underlying phenomenon that patients call fatigue. Patients almost always complain about being tired and fatigued. And that could be because they didn't get a good night of sleep, maybe because they haven't, in fact, had a good meal for a few days. But usually what fatigue means is the patient lacks motivation. So what I do with my patient when they say, I'm tired, Dr. McIntyre, I'm tired. And then I try to get into the weeds of this, saying, okay, are you tired just generally? Or do you find that you lack the motivation to do things? You don't want to meet friends, you don't want to go to work, you don't want to go to the gym, you don't want to do your chores around the home, and try to understand behaviorally what they mean. What I've been quite struck by is that many patients who say to me, I'm tired, I'm fatigued, actually are not tired and they're not fatigued. They lack motivation to do certain things, hence they are fatigued, but in other things they love doing it and they don't have any fatigue and any lack of energy. So I take this conversation more in a behavioral direction. I want to thank you all for submitting the questions, the audience that participated in our symposium today. It's been a lot of fun for me. And I also want to thank all of our listeners for listening in and participating on this podcast. This is Dr. Roger McIntyre.
Thanks for listening. Stay tuned for the next extended Q&A sessions from NEI Synapse.